Will I stay on, Derek, or will I come on when you introduce me, maybe?
I'll if you want to stay on, Mirish, that's fine. Yeah.
Okay.
This would be a short intro. So Shannon, can I go ahead?
Just give it a couple seconds. There's all the attendees are kind of funneling in from their waiting room. So
okay.
I'll let you know when the numbers kind of slow down so that we can make sure we have as many people on here as possible before we get started.
Okay, so we'll give it an extra minute then.
Yeah. Okay, I think we can go ahead and get started now.
Thanks, Shannon. Hello, everybody. Good morning. It's Monday morning, the 20th of September, and we're kicking off this first in the series of IPPOSI Digital Discussions for 2021. My name is Derek Mitchell. I'm the CEO of IPPOSI, and I'm joined this morning by a number of panelists who are here to discuss a number of topics under the broad theme of health information in Ireland. It's certainly been an interesting 18 months since the advent of the pandemic, and there has been a number of impacts both nationally and indeed locally in terms of health information and how it is collected in the first instance, but also used for different purposes. And we're delighted to be joined this morning by Mirish O'Connor, Assistant Secretary of the Department of Health. And Mirish will give us that helicopter view from the policy perspective on health information, both in terms of the response to the pandemic, but also what we're hoping is that it will lead to further discussions around maybe the fundamentals that need to be put in place to ensure that we have a sufficiently robust health information system, but one that has the trust of the Irish public. And certainly the impact of the recent verdict of our citizens' jury is very much close to our hearts, and certainly what the jurors and the jury as a whole has recommended is certainly in keeping with that citizen-based approach that we're very interested in here in IPPOSI. So my thanks to the organizers of the event, that's the IPPOSI team, and indeed the sponsors of this digital discussion series, and we'll be thanking them individually towards the end. But without further ado, I'm going to introduce Mirish O'Connor. So Mirish is someone who's quite familiar to many IPPOSI members in terms of his attendance at events around things like person-centered e-health and things like dynamic consent and data protection. But Mirish more recently has been, and it's actually Mirish, only on my reading of your bio, I realized just how many different things you have been involved in and contributing to in the pandemic, both from an official response in both in terms of the pandemic response, but also the response to Brexit. And also some of the more newer initiatives that are very focused on research and innovation. So from my perspective, I would certainly like to thank you, Mirish, for all of the work you've been doing in the last 18 months. And I think you're due an awful lot of credit for that. And I look forward to hearing of some of the impacts of those new initiatives that have come forward. Mirish, if you want to take the floor, and I know you have a couple of slides, so we might kick off the presentation, and then I'll introduce the other panelists in due course. But if you'd like to set the scene for us this morning, you're very welcome.
Thank you very much, Derek, and good morning, everybody. I'll footer here for a moment to share my screen. And Derek, if you could confirm when this comes up, is that?
Yes, Mirish, that's up, yeah.
That screen is now shared. Okay, good morning, everyone, and I want to thank IPPOSI for organising this event. It's a very welcome opportunity, I suppose, to get our heads up and try to take stock of the lessons learned from the pandemic response. I suppose I'll just start, before the pandemic. I think all of us in this audience and all in Ireland more generally, we absolutely did recognise the critical importance of health data and of health research. And we regard it still, and even more than we ever did, as an absolutely critical enabler of health service improvement, of advances in medical science, and of population health and well-being. One of the things I was saying to Derek just in discussions and with other panelists about the preparation for this morning is it's really, certainly from inside the Department of Health, the dust hasn't settled on the pandemic. The department is kind of buckled out of shape, like departments of health in all over the world at the moment. The pandemic response has been a phenomenal effort that has extended right across government and academia. And I would just caution in my giving my reflections today, I would say that the dust hasn't fully settled, and the lessons are emerging lessons. And I think it'd be really interesting, maybe other people on this call, I think, might have a sort of a clearer view than I might right now of the lessons from the pandemic. And I really look forward to our discussion later. But I was just sort of in my own thoughts. I mean, I thought it was an absolutely stark and clear illustration of the importance of accurate and comprehensive health data at national level. This, I think, was a vulnerability in Ireland. I suppose when you compare the early phases, even of say of vaccine rollout in Ireland, to say the Scandinavian sort of gold standards, where they have population health registries, where when it came to sort of prioritizing people with underlying health conditions, they could refer to sort of subsets of their national health registers and allocate out at a national basis like that. In Ireland, the vaccination program has been enormously successful. But in the early stages, the absence of a centralized sort of database, national database, and of a kind of comprehensive set of unique IDs across health data left us a little bit exposed. And we worked very much through healthcare service providers and through GPs in particular in sort of giving them discretion to determine people with underlying health conditions and that. The vaccination program actually has huge lessons because then from early April on, the HSE stood up the COVAX system, which is a national database. And anyone, most of us, I think, that would have applied for a vaccine, that sort of logging through online with the portal, confirming a phone number, confirming an email address, providing basics of ID like PPSN and so forth. That has generated one of the finest illustrations of a national database here in Ireland. And it was a real illustration of the HSE sort of building a plane as they flew it. And huge credit is due to the Office of Chief Information Officer in the HSE, to Fran Thompson and his team for the work done there. I think the pandemic also shows the value of public sector collaboration and innovation. And as Derek sort of touched on in introducing me, I had the privilege, I suppose, of being involved in a number of sort of very interesting collaborations. And there was a huge amount of fellow public servants who ran to the fire, you might say, when the crisis broke out, and sort of reached out to us in health to see what they could do. So that help, I mean, of interest for us this morning, there's a COVID data hub that the CSO were instrumental in supporting HSE and the department in establishing. They worked with HRB, the Health Research Board, in that, and used the power of the Statistics Act and their authority then under that act as statistical officers, officers of national statistics, to combine data in ways that we hadn't been able to do before. And after combining it, they were able to de-identify it. So it had all those good practices and securities that you might expect, and that might be, we want to become a feature of future policy. The importance of unique IDs in linking information and in authenticating the identity of citizens is absolutely vital. I mean, in any sensible vaccination program, linking dose 1 and dose 2 and all those very basic things, understanding the share of the population at different age cohorts with different profiles that had been benefited from vaccination, all that requires kind of unique IDs. And one of the lessons, and I'd be interested in the views of the panel and the audience, we have done huge work over in the background over recent years on the individual health identifier, and there was a big debate about the PPSN and the individual health identifier many moons ago in health. And while we had legislation in place for the IHI, and while many of the systems in the HSE were sort of progressively building up the coverage of IHI in them, when push came to shove in the crisis, in the pandemic, it really was the PPSN that the health services had to rely on at that point of interface. It's what people know. I think none of us remember many phone numbers anymore, but one of the few numbers that kind of lingers, I think, with us is our PPSN. And there is value, I think, in reflecting on that. And perhaps in the future, it's unrealistic to expect people to know the IHI like they do know the PPSN. And I don't know, I'd be interested in people's views on the use of that. The importance of building up and investing in the statistical capability of the health services was phenomenal, was an important lesson. And I think huge credit is due to the HSE for the databases they set up in the delivery of the vaccination program. The contact tracing database also is a phenomenal database of some scale that I think has good lessons. The value of population-based approaches and national level databases was really clear, and people's eagerness to have access to health information, to access their own information, and also to access sort of up-to-date, reliable sources of information on the health situation, I think was really evident. And that again came through in the IPPOSI citizen jury, which I'll touch on later. On top of the pandemic, of course, in Ireland, we had the cyber attack, very, very serious attack on the HSE primarily, but also on the Department of Health. And that was a very serious incident, which continues to have repercussions. And I think it highlighted the fragility of the IT and data management infrastructure in our health service, and the importance of security in the context of the rollout of health information. So one of the, in looking and speaking to sort of health information in Ireland, I was looking for sort of what had happened, say, over the course of the 18 or however many months it is now of the pandemic, and whether we had sort of more up-to-date assessments that had been conducted. And interestingly, the National Statistics Board, which determines national policy for statistics and also ensures sort of oversight of the Central Statistics Office, they produce strategic plans on a regular basis, and they refreshed their strategic plan earlier this year with a publication, Quality Information for All. And interestingly, they majored on health and social care as well as other areas. They identified the substantial gaps in the health data infrastructure, the weaknesses and lack of kind of comprehensiveness of our private sector data, prescribing data, primary care data, the challenges around the slow rollout of IHI, and the challenges around linking different events in a very complicated health service. They also pointed out that workforce data was in need of improvement. They expressed strong support for the Sláinte Care commitments to organise services on a population basis. And they felt that this was really, really important in the ability of Irish health and social care services to leverage the value of the national statistical infrastructure. So the census of population, for instance, is an enormously rich source of data on every single household in the country, by geography, by socioeconomic background, by caring responsibilities, the size and nature of the household, disability status, everything is such a rich amount of information. And we can infer an awful lot about the health needs of a population on the basis of those sort of demographic indicators. But I think what Sláinte Care recognised is that the Irish Health Service isn't utilising population-based approaches in the way that other countries do. And this has an impact on the quality of service, but it also, and perhaps in a related way, has an impact on the service's ability to be evidence-based. The National Statistics Board, and this will be of interest to IPPOSI, they noted the commitments that existed pre-pandemic to develop a health information system strategy, and they demanded that that strategy, or a health data strategy as they called it, be published by the middle of next year and implemented with sort of urgency. So that I thought that was interesting. And in sort of preparing for today then, like I say, we got pulled in all directions like every other health service over the last 18 months. And I looked back in preparing for today on the kind of work, the bank of work that we had in place around the health information system strategy. And much of it holds up very well. And here's the vision statement from the earlier period that I think holds up very well. The strategy is intended to improve the care people receive, their outcomes and the well-being of the population by ensuring high quality health information is available to the public, health and social care professionals, researchers and policymakers. And all those principles set out remain entirely valid. And I was encouraged actually to see how relevant our earlier work remains. Key themes emerging from the earlier work are set out in this slide, and I'm happy for IPPOSI to make copies of these slides available to participants here this morning afterwards. This is almost a kind of a whiteboard really of kind of topics that were emerging, and a lot of these themes actually again were picked up and sort of further developed, I think, by the deliberations of the IPPOSI citizen jury on health information. And like I say, this is available to us now as we kind of take stock of lessons from the pandemic and think our way forward in terms of health data strategy. Health information in Ireland, anyone that's heard me speak before, I nearly always use this quote from Howard Johnson of the HSE. It was one of the first meetings I had when I joined health back a number of years ago, and he said, Murish, health has lots of data but little information and less intelligence in terms of intelligence signals. And I remember at first I came from education sort of background, and in the area of education it's improved an awful lot since. But in my earlier career, a lot of the times in statistics or in research, it was about sort of filling data gaps that existed, real blind spots that existed with meaningful data on maybe student dropout, on sort of participation or retention by socioeconomic background, all these issues. And there was a big effort needed often to generate and fill these data gaps. In health, when I joined health, one of the things I noticed, I was absolutely blinded by the volume of data, of information flowing around the health services. Huge amount of sort of noise, really, huge amount of metrics, just thousands of pieces of information on spreadsheets in tiny font exchanged on a monthly basis between HSE and the department to support us in our oversight role, in our role as accounting, the SecGen's role as accounting officer for the investment. And at first, I understood the challenge that I was set and the challenge of my division to decipher signal from that noise. And we dived in and tried to look at where the most efficient sort of delivery of service was. And we struggled to sort of connect the various pieces of information. And I suppose over time, and it was a slow lesson to learn, it wasn't that my job was to decipher signal from the noise. It's more, I recognize now, about the Department of Health needs to organize the noise in ways that deliver signal corresponding to what it is we value. And a lot of the noise from the health system is service metrics. So it's the quantums of people waiting for service, it's the length of time waiting, it's the numbers discharged, admitted, it's all lumps of sort of people often behind it, or lumps of money, and it's kind of service metrics. And one thing that's impossible to see in the middle of all that noise is the health and well-being of people in Ireland. And that's the core mission we have as a Department of Health. It's the core mission that the HSE has as a national health service, to improve the health and well-being of people in Ireland. And it kind of was very humbling for me to recognize that for all the noise generated and the huge amount of work it required of busy people trying to deliver a service in generating that information, that none of it delivered signal corresponding particularly well to the health and well-being of people in Ireland. So one of the things that one of the sources of that confusion is the existing organization of facilities. And that phrase, the existing organization of facilities, it was a phrase that ran through the education report of the 60s, investment in education, which led to the free second level education. But the OECD team, comprised of Irish researchers, a lot of them at the time, were very, they were committed to the universal provision of second level education, and they became obsessed over the course of that report with the existing organization of facilities. And I like the plainness of that language. But one of the things, when we look at Irish health services and how it's organized, it sort of does explain why some of the noise is so incoherent. And I'm not going to go on about it this morning, but it's quite a hot issue at the moment in the context of Sláinte care reform. But this mismatch between our organization and management of hospital services and our organization of acute and community services and other services is a key part of the challenge that we have around sensible health information. So we have six hospital groups plus the Children's Hospital, and then we have 9 community healthcare organizations. And you can see how the hospital groups don't overlap at all well, particularly on the East Coast and in the South, with the community healthcare organizations. So the hospital group there in yellow covers at least 3, definitely maybe 4 different CHO areas. So all this talk about sort of integrating care around the needs of people and person-centered care is really difficult to organize when you have such a complex web of interfaces between different service providers. The Sláinte care plan was to develop and adopt population-based approaches and to organize health and social care services around sensible geographies, corresponding with minimal disruption to the CHOs. You can see the new proposal kind of respects as good as possible the kind of the structure of existing CHOs, and then makes sure that the hospitals in those areas are sort of understood to be delivering service primarily to people of those areas. And this kind of approach, the existing organization of facilities, is an absolutely relevant discussion to have when talking about a health data strategy. because one of the things here, for all the noise that's generated in health from the existing approach, it doesn't leverage or benefit from in any way the huge amount of other effort Ireland makes with the CSO, with other departments of government, with social protection and others, to understand the needs of the population. So I do think person-centered approaches require population-based approaches to healthcare. I think they're one and the same thing. So health is part of a broader evidence base. I think I've made that point enough now in the last slide. Building trusts is absolutely vital, and we recognise that. Ensuring security, as I say, electronic health records. We are behind the curve internationally in the rollout of electronic health records, and I'd be interested in people's views on how we might go about that now. I had absolutely limited success, I would say, in trying to do the top-down approach, trying to secure major level investment, Department of Finance and others, and invest in EHR, say in acutes, in communities. And I'm now thinking post-pandemic, and with some of the lessons, that a more bottom-up approach might be better, where we reach out more directly to citizens in generating, providing access to healthcare records, rather than trying to work through every single service provider and connect all those. I think some more direct approach to the development of access to the facilitation of access to health information for each and every citizen, and then requiring health service providers to support the citizen's right to have accurate, comprehensive, up-to-date health information available. There's EU developments that we can build on as well. And I think just because we're behind the curve internationally on something, it doesn't mean we have to. There's quite a bit of advantage in that. And we can see and learn lessons from the best of international practice, and maybe take direct routes to some of the best practice. And I do think there's some very interesting EU approaches, and I think Ireland can benefit an awful lot from them. And the EU approaches deliver real value for our citizens, because, for instance, the EU have an idea now of a basic template for health information that should be transferable all across Europe and readable all across Europe, that would be minded no matter what member state we're in, and that no matter what member state we're in, that they would have access to a core set of critical information for us. There's a project to have e-prescribing and prescriptions recognized across Europe. And these international templates, I think, provide a very obvious templates for us to plug into nationally, because for all the positives about innovation, the last thing you want in good data collection is innovation. Actually, you're best generally to find standard classifications from international standard ways of asking questions, of recording information, and adopting standards rather than innovative sort of fancy new approaches. So one of the issues and one of the challenges is that the health data is a hot potato in Irish law, as it is elsewhere, and even the GDPR, which is kind of the answer to everything in terms of data, and there's an awful lot of positives to it. It's a very comprehensive piece of European regulation that operates as law right across the union, that serves as a template more globally. But even the GDPR kind of boxes off health a little bit, talks about the particularly sensitive nature of health data, the particularly personal nature of health data. And it kind of says that member states need to develop additional suitable and specific safeguards because of that sensitivity. And it doesn't always, in fact, it leaves it very much to member states to specify those suitable and specific safeguards. The Irish Health Data Protection Act of 2018, which coincided with GDPR, again had the same sort of sense of particular sensitivity around health data. And even the recent, there's a data governance and data sharing piece of legislation enacted by Department of Public Expenditure. And again, they kind of explicitly said that it wasn't dealing with health information. So health information is kind of, people have a kind of a wariness of it. People kind of, it has a complexity and a sensitivity that I think makes it an even bigger challenge. And I suppose one of the questions that maybe I'd be interested to hear from the panelists and from our audience today is it time to consider primary legislation to clarify the basis for the management and sharing of health data? Is there legislation needed as well as a data strategy? I just want to, I expect there's a good number of the participants in the citizen jury in our audience today, and I just want to say how impressed I am with the report, how encouraged I am. I was looking at it in good detail over the weekend, and it's really encouraging, I think, the endorsement it has for the instincts we had before the pandemic, the demand people have more and more to access their own information directly. There's some interesting things about an independent champion for public health information. There's an eagerness to have access to comprehensive electronic health records. And then there's some very, the limits as well are clearly, like, information has to be respected. Health information's sensitivity has to be treated with robust security measures, strong sanctions for any kind of misdemeanors around health information. And interestingly, I was really encouraged by the recognition of the importance of health information. While health information at an individual level is very personal, health information at an aggregate level has huge value for science and for research, and the support for sort of the development of secondary uses to support medical research, to support health service improvement was really encouraging. And I just want to say thank you to IPPOSI and to all the participants in this. And we will absorb this and ensure that it informs our work going forward on health data strategy. Intentionality, just this is a nice definition, and I think in a way GDPR is very complicated. I would say to people, there's a lot of stuff written about GDPR, and I would advise you go directly to the GDPR if you're curious about something. It's quite there's a lot of complexity talked up around it, and the GDPR, I think the main way to the most important thing and the most important way to deal with this sensitivity of health data and the particularly personal nature of it is to make sure that everything that happens, health information, is deliberate, it's intended, that it's performed with awareness, that what we're doing with health information is done consciously on purpose. Because when that's the case, then you can clarify to the people whose information it is, those purposes and exactly what's done. And this idea of explicit consent, consent is only explicit when it's fully understood what is being consented to. So I think that sort of simplification in a way that we need to achieve in sort of health information strategy is really important. And the IPPOSI report, I think the dynamic consent, the idea that one-off consent is a bit sort of superficial, and there's a kind of a live consent that's needed. And I think this kind of intentionality is something I would want to put at the center of any Irish health data strategy, to support that sort of clear understanding among the citizens about what happens to health information and what doesn't happen it. So that's just a repeat of my opening slide. And I would say that while we recognize the importance, the critical importance of health data and of health research, and I haven't covered research or done justice to health research in this particular opening remarks, but happy to talk to it in Q&A if that's needed. is even more, we're even more conscious of the vital importance of health data. And I know there's enormous challenges in the health service. And like I say, as the dust settles, things like waiting lists and access to services, which was the real challenge and the real weakness in Irish health services, they remain. But I hope that in the context of addressing those huge challenges, that we do find time for some of the fundamental reforms in health. And I would say a health data strategy is one of the most fundamental of the fundamental reforms that are needed. So thanks very much, and I look forward to hearing the other contributions and input from the audience. So thanks very much.
Thank you, Mirish. That has been a very insightful and I think a very honest appraisal of where we're currently at. Certainly lots of challenges remain, but I think it's important to acknowledge that some successes have happened, not least as a result of the work of many in the public sector. But I think in particularly for the audience of today, certainly the challenges for those engaged in either, as you say, the secondary purposes, the secondary use, in particular research, I think will bubble up, and I look forward to those conversations. Just for the audience, just so you know the format, so please feel free to enter your questions or comments that you may have throughout the next, hour and a bit, and those questions will be put to the panelists. I'm going to introduce the panelists individually, and I'm going to ask for their individual perspective on both what Mirish has presented today and also from their own context. And I'll introduce them individually, but please, audience members, please feel free to keep continuing with the Q&As, and we'll bring those in once the panelists have had a chance to respond. So the first panelist I'm going to introduce is Loretto Grogan. And Loretto, if you would like to, yes, great to have you. And again, Loretto would be familiar to many people here in terms of a presentation she gave 2 years ago now at our Electronic Health Records conference. And certainly Loretto remains really well placed to talk about not just the value, I think, of new innovations in certainly in the maternity services. I think it remains the single electronic health record in the country that has been rolled out, and we would certainly be interested to hear about what challenges you've faced in that, but also maybe some of the successes. And certainly, I think in terms of your own work in the HSE, in implementing some of the policy initiatives that are coming down, not just in the last few years, but are coming down the tracks in the next few years, as Mirish has alluded to. So, Loretto, I'll ask you to give us your perspective.
Great, thanks so much, Derek, and good morning to everybody. And first of all, thank you for the opportunity to be here this morning. And just to follow up on Mirish's really insightful presentation, the report, the IPPOSI report, was a super piece of work and really insightful, and it's a really great document to have going forward. First of all, just in terms of, I think the last number of months we have a positive legacy that we really should look back on. We've developed systems like the COVID Care Tracker, COVAX. We've introduced telehealth nationally. So I think we need to look back and sustain and improve upon what we've done well. I agree with Mirish that we need to take a step back, and we need to look in and look and take all the learning in terms of strengths, weaknesses of our current infrastructure, and also the opportunities that we have now. I guess of note from Mirish's presentation, in some ways we have a really, really great opportunity here because we're a little bit behind some of our EU colleagues. We have learning, we have our own kind of national learning that we can look upon, but we also have a lot of international learning that we can take from as well. And we have a lot of colleagues. I think the last number of months have shown how we can collaborate, not just from nationally, but also internationally, and how willing colleagues are in the kind of digital health space to enable collaboration. I guess just in terms of health data, it is so important. I guess a good digital health infrastructure is fundamental. Data is fundamental to the health and well-being of our citizens going forward. It really, really is. And getting that right and making sure that the right information is in the right place at the right time to ensure safe care is a fundamental component to health data and to that citizen-centered approach and that person-centered approach to healthcare. So I guess just to start by saying that healthcare data is, and Mirish has alluded to this, it's complex. In Ireland, our healthcare data is stored in many different places. It's stored on desktops, it's stored in servers, it's now stored in a lot of vendors' clouds. Data structure, how our data is structured, we have some structured, unstructured, it's hugely varied, and we probably have a gap in terms of standards or data standards for that. Also, like Mirish said, legislation and regulation is very necessary to have our data regulated and legislated for. But again, we probably do have some gaps there in the system at the moment. How our data is formatted, again, is a huge challenge. We have data in PDFs, we have data in like various kind of imaging, JPEGs, many different formats. Our data definitions, again, we have got a challenge there. We're trying to put a data dictionary in for health, but they're very subjective based on the source. And again, our data, health data is complex. So you're taking data from humans into data warehouses. That itself, there's a level of complexity to that. And I guess just in terms of complexity, I'm going to talk a little bit about governance. And I agree with Mirish that our existing organisation of facilities is complex. It is a challenge when we have our hospital groups and our CHO services, and we're moving towards that integrated care agenda. When our existing infrastructure facilities is complex, then trying to actually move towards that integrated care agenda to keep our health systems connected, to connect our data, that lends itself to that complexity. So I'm just going to talk quickly about kind of 4 key areas. Governance, again, it's really important that we get this right for digital health and for data. And at the moment, we have a number of bodies that are kind of leading out and funding digital health initiatives. And there probably is a lack of connectiveness in terms of, we have colleagues leading out from CHOs, planning and strategies, social care funding, etc. That all has to be connected, and the governance for that has to be connected. And again, we all need to be working towards a common and shared vision, common strategy, a common roadmap for our health data. So everything we do is connected. Everything we do is working towards that common vision, that person-centered. And that connected healthcare is really, really important, and particularly when you're talking about person-centeredness and the integration. And again, just the fundamentals of digital health, getting those fundamentals right, like our IHI program. Having a really robust IHI program is essential to ensure that we can identify patients in our system, and again, to enable that level of connectedness. And again, digital health is all about our people, process, technology, in that order, people first. And we have to get that process and technology right. And again, I know Mirish mentioned our EHR program and the top-down approach and how challenging that is. And again, that's one of the things, the key learning from the last number of months is that agile development. It's starting at learning, iterating, learning again, iterating, or else going, this isn't working, and failing fast. So Mirish, I'm going to just, or not Mirish, Derek, I'm going to finish there. I'm happy to take any questions from the panel and from colleagues on the meeting. It's a subject I could talk on forever, but they would be some of my key areas. Thanks, Derek.
Thanks, Loretto. And certainly, I think in terms of your 4 key areas, I think you've hit on the essentials that we're hoping to get more in depth on, certainly in the later part. The next panelist I'll ask to activate their camera and join us is Rob O'Connor. So Dr. Rob O'Connor is the head of research in the Irish Cancer Society, and I think is acutely aware of the value of health information, both from the point of view of services delivery, but also in terms of drivers of health research and innovation. And Rob comes to us this morning as a former IPPOSI board member and also one of our key patient group members, and has been for many years. The Cancer Society crosses a number of different jurisdictions in terms of health information, and is well placed to give us a perspective on what both Mauritius has talked about, but also from the Cancer Society, and maybe even might touch on the subject of registries. So Rob, please give us your perspective.
Good morning, Derek, and good morning to everybody attending virtually today. Hopefully the next one we'll be able to do in person, fingers crossed for that. I suppose that a few musings from Murish and Loretta's insights there this morning. And I suppose maybe just to start out, in keeping with the topic, learning from the pandemic response, a few things that came to mind for me, certainly seeing in the cancer space. Our health systems at best were hanging on by their fingernails before COVID hit. And I think COVID and the impact of COVID has shone a very stark light on where we have stood as regards health data, and our ability to recognize the challenges that come before us. I think COVID and our community approach to COVID has also shone a light on just how vital data is. There's a very interesting experiment going on in this island where we're comparing two different health systems within one geographical boundary, and the differences now come is quite stark. But our community has been living on data. Our health service, everybody has been looking at that data. And I just can't understand why we don't see the same value of that data into other health systems, into other diseases, into other areas of health. And we don't see how that is, I suppose, interconnected. So maybe COVID has shone a light in what many would have been talking about, and I suppose trying to articulate to the powers that be around that. And I suppose the other aspect is the scale of the challenge that we face is absolutely enormous. And I think we have to face up to that challenge. For example, in cancer, we know that within this generation, the numbers of those affected by cancers, by invasive cancers, will double. That is a very dark cloud on our horizon. And if we're struggling at the minute with what's going on, how are we going to manage our way and make most effective use of resources to be able to enjoy on an individual and community basis the benefits that research and health and data can give to us? So I didn't want to waffle on too long, and I am keeping an eye on the time, but arising out of the two previous conversations, and indeed some of Derek's points, there were 5 things that I sort of came up with, maybe in some sort of ranking. The first one is, I think we have to face up to that challenge, as I mentioned, to the scale of that. And I suppose maybe as a community, we've been a bit afraid to face up to these things, face up to the growing dark clouds around us in terms of our health. We've maybe benefited, we've seen significant increases in the life expectancy of people and so on. But I think we have to face up that this is a tens, if not hundreds of billions of euro challenge that faces us in the coming decades. And much as we faced up to what was coming down the line with COVID, and essentially blank checks were written into our health service to be able to deal and keep our economy going, keep our health going, and try and hold on to our health system. I think we have to face up to the truth in all of those other aspects of health as well. This is a phenomenal scale, a phenomenal challenge, and we are going to need health data to be able to understand this and to be able to devise mitigations. I think a team approach is my second point. And again, out of COVID, I think we saw that team approach. We saw it in our Department of Health and our HSE, in the amazing people that make up our health system. We also saw it in our community. We've seen such a great uptake in vaccination, more than 90% of those above the age of 16 contributing to that community health effort. So I think we need to work together as a team. And I think we need to identify the commonalities in our goals of each of us wanting to get the best life and the best life expectancy and the best health outcome from everything that we can for those in our community. I think trust is very important as my third point. We need to be able to have trust in that data and trust in that information. And I think in some situations, there is fear around health data and fear around what we're going to see if we actually start looking into health data, what we're going to see in terms of the unacceptable wait times for many people, whether that be cancer, cardiovascular disease, diagnosis of whatever. Wait times in particular are critically important to tell us how quickly we're able to get in and mitigate different health conditions. My fourth point would be time. I think there was an urgency around COVID, and that urgency allowed us to overcome certain inherent logjams and roadblocks around setting systems up, and people were empowered to be able to make the right decision. I see some questions coming in about registries. I think registries are absolutely critical, and we need to get those systems in place now. We don't have time anymore, and we need to see the same sense of urgency that we saw in COVID coming into other aspects of health. And my final point is something that I think both of the previous speakers touched on, and I just want to call out and I suppose reiterate in a stronger way. Our system needs to move to focus on health, focus on people, focus on the needs of people, not focus on hospitals, not focus on hospital groups, not focuses on what suits a political agenda or what can get a short-term benefit for someone for maybe taking a hit or a knock or maybe from not facing up to some of the challenges. We have to turn our system around to deliver on the questions and the answers that we need to be able to make sure that my parents, my family members can get the benefit. Not that it suits a particular hospital group, not that somebody in one part of the country maybe doesn't have the same sense of representation, not that maybe treatment is better in one part of the country than it is in the other. And I think for too long we've accepted this focus on the system. And if we're going to move to something, whether it be bottom up or top down, that has to build in the ability to focus on the needs of that person, getting them to appropriate healthcare in a timely manner, getting them world-class support for whatever their condition is or might be. And too much of what we do tends to focus on the problems with the existing system, the problems at a particular hospital, whether there's communication going on and all of those other elements, not actually looking at us as individuals and what do we want out of a health system. So those to me are some of the learnings from COVID as we are at this stage in the COVID pandemic. And I guess some of the vision of, I think, where we can go, recognizing the challenges that are ahead of us and where we need to go. And definitely health data is critical to be able to devise and develop those mitigations. We have a big challenge ahead of us, but I do think that if we take the same approach, we can overcome those challenges and enjoy the health benefits that we would all hope for ourselves and our families. So I'll finish up there, pass over back to you, Derek.
Thank you, Rob. And again, some really, really important points facing up to the challenge. And also that, I guess, that twin challenge of balancing economy and health. But I think certainly touching on what you've talked about in terms of the need for health data to both understand what the challenges are and to devise mitigation strategies is certainly the one point that I'm certainly taking away in addition to the others. Lots of questions coming in as a result of both your and Loretto's interventions, and thanks to you for entering those questions. Please keep them coming. Our final panelist, last but no means least, is a member of our citizen jury, and that is Sarah Hurley. And Sarah, I'm just so delighted that you can join us today, and I know you've taken time out from your work to join us. And it's very much in keeping, I think, with a lot of what's been talked about already in terms of bottom-up approaches and citizen-based approaches, but also even something that has come through about younger populations, and how I think Rob touched on it in terms of the vaccination program, and how that community has really come together at the national level. And it's been wonderful to see that response. And I think that's definitely a learning that can be taken forward. But of course, you're here to both represent the jury recommendations, but also here as an individual citizen. So delighted that you can join us, and please give us your perspective on what you've heard to date.
Thanks so much, Derek, and good morning to everybody, and hello to everyone in the audience. I was one of 25 citizens jurors that took part in a citizens jury on access to health information. And we also included discussion around secondary access to health information too. It was a really fantastic experience. It's probably the first citizens jury that Ireland has used, and we've seen like other citizens deliberative justice models kind of coming up specifically in climate change and gender equality. So I think that this is a really timely discussion that was had. So we did come up with 6 recommendations, but there were a multitude of themes. And I just want to express that the process really gave us the time to consider what the kind of the current state of the public health service here was in Ireland, and also what we would want as citizens going forward in future, especially around a digital health future, which is often, which wasn't necessarily the experience that most of the jurors had come with. Just to give you a little bit of background, I have been living in the UK for 10 years, so I have a lot of experience with the NHS. And coming back to Ireland, and my main reason for partaking in the citizens jury was because I wanted to work on and support mechanisms in which quality care is given and is generated through a citizen's directive and response. And it could be and it is a co-collaborative means. Without the healthcare system, without the data, without the patients, no proper healthcare service can really be delivered. So I just wanted to mention the themes that came up, and I think that they're very relevant to what Murish, Robert, and Loretto have mentioned already. So from the perspective of the jurors, we needed a connected, quality digital health information system. We need an independent oversight of our health information. We need to partner with citizens to design our health information for a digital health information future. We need citizens to be the owner of their information, and we need consent to be the cornerstone of everything that we do. We have a collective responsibility to do the right thing. So by that means that there's an understanding from the jury that the sharing of our patient health data through understood mechanisms of consent is necessary for quality of care, but also good quality research and being able to plan the health services needed to support Irish patients. We also need to treat this data as a national resource. The fact that this can be beneficial to patients, but also to our health structure, gives an acknowledgement that there is value to this data. Alongside with the value, we also recognize that there needs to be an accountability mechanisms built into how our patient data is used and shared and accessed, and that these need to be supported to grow trust and confidence in the state. The reason why I wanted to kind of give you those overviews was just to give you an insight to what the themes came out, but the context in which we did the citizens jury was obviously we were sitting in our homes. We weren't able to meet because of the pandemic. We met in April for 3 weeks, and we had 6 sessions over those 3 weeks, and those were actually bookended by multiple news stories breaking around scandals around the patient, around mother and baby homes, the people that were within that system, their access to their health information, the autism dossiers, And then at the end, a week after our jury concluded, we saw the cyber attacks. So with that in mind, I would really encourage everyone to engage with the report, because it really, I think, had very strong recommendations that, like Mur said, need to come from a bottom-up process, and that's a way of including the patient and the citizen as the center of what the care is to be. Marish also mentioned, I think that was a really good analogy, that the plane was being built as it was being flown. And I think that now that we have this possibility to take a step back and reflect, that the passengers really should be included in kind of understanding and building a better plane. As I like with the public health citizen strategy, public acceptability, the public acceptability was mentioned as one of the key points that need to be considered with building our future health service. I would say that public acceptability is very important, but public acceptability should not be superseded by public engagement. So taking a position where the citizen is included in every part of the process of building this digital health structure, I think would be the most beneficial. And like I said, the social value of this health information and the secondary uses have social value too. So I think that from many learnings that you might be able to get from the EU should also be considered in building a unique system that's suitable for Irish citizens and our health service and where we aspire to be. So from a bottom-up process, I think that citizens' rights, the legislatory aspect of that needs to include the patient as owner and controller of their data, and to engage with their care providers about how to have quality access to that information that helps to create a quality outcome for services. And that quality outcome of services needs to be equitable across the whole island of Ireland too. I'm really heartened to hear all the progress that has been made. And I think that the report really does tie into some of those more challenging aspects that the other panelists mentioned around how to get informed consent, how to get buy-in from the public. And I really encourage using the report as a guiding document to help support that. Thank you.
Thank you, Sarah. Wonderful contributions, and I think it's safe to say that no matter how many times we in IPPOSI design either patient engagement or public engagement, it's continually expressed to us from the quality of the reports that we're able to put together is a certain degree of surprise expressed by those at maybe the policy level on just how in-depth you can go in terms of these tricky topics, and just how much that people can understand and appreciate the value of health information if you engage in an appropriate way. And certainly your points around how that bottom-up approach can really incorporate elements of citizens' rights and rights-based approaches is certainly something we would be interested in exploring more, certainly in IPPOSI. So if I ask all of the panelists to maybe come back in, I know you're still there, but so everybody can see, a lot of common themes coming up, and a lot of there's a couple of questions coming through. And I know that I have the power in terms of moderating and that, but I'm also conscious that I'm trying to get in as much as possible. So one of the things that struck me coming through there was this need to reflect on what we've learned from the pandemic, but also this sense of urgency that health information and maybe patient data that it has struggled to achieve in terms of those kind of important decision makers really appreciating how this needs to move now. And in terms of articulating that public value, almost a proposition, is something that certainly we've struggled to understand what the challenges are and maybe what the fears are. Merj touched on it a little bit in his talk as well. But in terms of maybe elevating that conversation to that combination of reflecting, but also urgency. Can I put it to the panelists, what you think are the key value propositions that we can be communicating around health information right now to those decision makers? I'm conscious as well that at our 2019 event, Laura McGahey stood up in front of our organization and said, the problems in e-health are not technical. We can do this technically, and that problems are actually and the obstacles are actually two-legged in nature. And I find sometimes that when you get to a certain point in decision making, health information tends to get bogged down in the technical aspects, but it's actually the people that we need to be communicating with and understanding why this is relevant for people's health and for the system to improve. I think that's where certainly we've struggled in Ireland. So I'll offer that up as an opening question, and then we can get to some of the Q&A coming through. So does anybody wish to come in on that?
Derek, I can come in if you like.
Thanks, Merj.
I haven't an answer to your to your question. As I say, in the department, like we've a new boss, Robert Watts, in charge here now the last while, and like the whole department. Honestly, I have a division. Even it was hard writing the bio because I have what I would have described myself, say 2 years ago. I've got a lot of other bits joined on because the department just sort of really has a new shape, just a crisis response shape, and there is a kind of the dust is now settling. We are, I mean, touching wood here, it feels like we are in the home straight, and huge credit is due to the health services and to the people right across the government. I'm conscious that while the pandemic, is a health issue, that schooling, social protection, employment, tourism, everything has been absolutely challenged by it, and so it's too early to say. It is that sort of moment where the health service kind of we're looking at the waiting lists, the trolleys again, the access issues, and I sincerely hope, and I'd be very much making the case in every opportunity I get, that like the instinct to prioritize now, which is absolutely imperative, that prioritization doesn't just obsess about the urgent, that it recognizes that the fundamental issues, sorry, I'll turn off the light behind in a minute, but it recognizes that some of the fundamental difficult issues like health information policy and strategy need to be embraced head on. And I would go further and say that the resolution of challenges such as waiting lists and access and accountability and even value for money are impossible to solve without a resolution of some of the fundamental issues. So the value proposition, how you might sort of argue that, I mean, one of the words that comes to mind for me is like amid all the complexity and the sensitivity of health data, what's most critically urgent is some kind of simplification of the whole system. And I think digitization and electronic health records in a more bottom-up approach do offer a way forward. And this is what I was saying about some of the international templates. There are some core minimum data sets that I think we should just set as basic milestones. I think every Irish citizen should be promised that some core data, their blood type, their medicines, their allergies, whatever else, there's a set that's kind of understood pretty well, will be recorded. I can come back to that because Evan Moreau and others in the audience were asking for elaboration. But I think simplification is something that I think, and a focus on allowing the health services to focus on the core mission. And I would say that some of the numbers we're looking at, some of the waiting lists and the like, what are we at? Like, you're hearing opposition politicians talk about 900,000 people waiting. So there's 900,000 procedures being waited for, or tests. A lot of them are tests being waited for. And it'd be just so much simpler to understand at people level what the needs are and what the urgencies are and what the priorities are. And even within the services to have sort of responsibilities described in terms of population health outcomes, and not just sort of these busy service metrics that really don't give any insight into the health and well-being of people in Ireland. Thanks.
Thanks, Marish, for responding. I see both Rob and Loretto are raising their hands. Rob, if you want to come in first, I think you were first in.
No, I actually think Loretta was in first there before me. So if Loretta wants to go ahead and I'll come in after.
Oh, actually, Rob, you were in first.
All right. We're so polite. I guess one of the challenges I see, which I suppose we're kind of dancing around, is that communication aspect around the value of data and systems and the organization of it. It's very complex to organize, but I think many of our policymakers have really maybe not fully understood the impact on day-to-day life. And to go to what Murray said, I think something that's simple, something that people can relate to, and people can relate to being sick, around the fear of sickness, the fear of having to wait for an x-ray, the fear of having to wait then after that x-ray for the result of the x-ray, and then get a consultant appointment and then to start treatment or whatever. I think relating those things to things that people can understand, and our community definitely do understand that. We've a very high rate of private health insurance in this country because people understand those challenges. And maybe we haven't communicated enough to connect the inherent need and value in some fundamental things like the health identifier, around having very robust, independent, trustable data sources. And as I said, I think in some cases that has been done because it has suited certain agendas, because people have been afraid of what some of those data things might show. And some of the data is truly shocking and frightening. And I've seen it in my own family of late. What happens in different parts of this country, and the wait times that some people have to have for the most basic of access is truly shocking. So I think communicating that, relating it, and some focus on that, as well as on the fancy stuff around how you set an identifier up and what it will mean and all of those other things, but bringing it back to personal.
Thanks, Rob. Loretto, if you want to follow that up.
Yep, thank you, Derek. No, I agree with what Murish said. We need to simplify, and we need to get our fundamentals right, because we have our fundamentals. We don't actually understand what they are. And when you talk about waiting list data, Murish, and that horrendous number, I have a sense that that number isn't probably, if you really delved into that data, people are on a number of different waiting lists. Their referral management system probably isn't where it should be. So the same person could be, the same person could be, you could have 4 different waiting events for that individual. And that's just the nature of where we are at the moment. So getting our fundamentals right. And again, our just understanding, to simplify, we need to actually break things down further. So like our data location, how's it stored? How's it structured? What's the legislation and regulation around it? What are the formats? How are we going to define it? And again, we have significant pieces of work to do those fundamentals to ensure we have a good infrastructure going forward. And again, I mentioned it previously, it's that roadmap. So we're all working. So you have CHOs, they're going on a digitalization journey that's totally disconnected maybe from the acute journey. In the acute service now, we have about 6 vendors, EHR vendors in the market. Again, we probably don't have the level of standards we should have to be giving to those vendors if they're standalone vendors, which they are. We have a number of our EHR, our acute services going off on different EHR journeys. And again, they're not building from the bottom up. That kind of user-centered, citizen-centric approach, we need to actually define that. We need to define what that looks like. We really, and again, I can't highlight enough that fundamentals, getting those right. And just one more point, just to follow up, is connected care requires connected teams, and we don't have that. And again, that's a challenge. Thanks, Derek.
Thanks, Loretto. Your point about connected teams is certainly something that rings a lot of bells in our ears. But I think even defining what the team is, and certainly in terms of the patient perspective and public perspective, in terms of really understanding, as many have said, not just the needs, but also including more participatory and more partnership based approaches across a number of different levels. And Sarah, I don't know if you want to come in with a viewpoint on this before we go to the kind of broader audience.
Yeah, I think, like as mentioned, the patient-centric, citizen-centric model from that bottom-up process is vital. It needs to be an inclusive model. It needs to be something that's easy for citizens to understand. Citizens being citizens as patients also. They're going through their journey, and they need to have the full understanding of what information is held on them and how that information is shared, how that information is accessed. Because that really is a fundamental aspect of caregiving as well, is having that access to the data about them, and being able to be agentic in how that is shared and used. Yeah, that would be my kind of contribution to that. Thank you.
Thanks, Sarah. So I'll move to some of the questions that are coming in, and hopefully that will lead to further discussion on some of the points we've raised. There's a number of questions coming in around patient registries, and really it can be probably encapsulated in the question from Philip Watt, who's asking, what is the role of patient registries in health data strategies going forward? So I think that's probably a question directed to you, Murish, in terms of if there's intentionality and if there's plans to really provide either a legislative base for registries or indeed greater levels of support and I think maybe standards between registries. Is that something that you're looking at that policy level to incorporate into future acts and strategies?
Thanks, Derek, and thanks, Philip, for the question. Yeah, registries are really important. In fact, some of the key strengths that we have, I think, in the health information system in Ireland, some of our registries, cancer registries, particularly strong and particularly good illustration. And I know there's a lot of other registries developed and maintained. One of the thing about registries is they're generally sort of disease specific or condition specific. And I observe over the years a lot of competition and rivalry, I think, between different aspects of medicine around registries. And I think registries are an absolutely critical part, but I'd rather build from the center out, not to sort of treat people on the basis of a particular condition, but to get a holistic view of the health and well-being of each citizen. And to be honest, my ideal would be a national citizen-centered health database that could be the fulcrum and the core platform for a whole range of registries, and that we would have, in the ideal thing, they say the DAZZLE model, where you have a national sort of information system supporting the delivery of care, And if we had a sort of a unique record and a good trace on the health and well-being and core variables of all citizens, the best registries would start as extracts from that national database and supplement it on the basis of sort of particular areas of interest. So I support registries, but I don't think registries are the path to a national approach. I think as something that the centre has to be built, and registries are very, some of them are really strong and give us a really strong start in core areas. So that's my view on registries.
Thanks, Marish. Rob, do you want to come in on that?
Yeah, I suppose maybe as a follow-on to what Marish was saying, and caveat that I sit on the board of the National Cancer Registry, 2 points. One, registries have to be resourced appropriately. And certainly I feel in Ireland, the National Cancer Registry has been held up as a shining example. And the work that the guys do there is phenomenal and hugely impactful. But it's not resourced to the level of international partners, and there are difficulties in getting the skill sets, etc. So that's one thing. The second thing is, I always look with envy at the Scandinavian arrangement, where every aspect of interaction with the health system is recorded. And that allows you to do a lot of cross-dimensional analysis. And I think this is maybe what Marish was kind of saying. People who get cancer also get cardiovascular disease, or they have various other health conditions. You can't look at health as a set of different silos. So I think there is benefit in having some specialization in particular registries, but I think you have to start from a basis of having a trusted and safe way to capture all of the relevant information, because you never know going forward where things may lie. And so for example, there's a lot of information coming out around how certain medicines may reduce the incidence and severity of certain types of cancer. And these things come out of larger health systems registries, as opposed to health systems analysis, as opposed to just having a single system. So the take home, one, we need the fundamental basis to be able to record a lot of information. And two, we need that specialization inherent in certain disease registries, but they have to be resourced. And if they're not going to be resourced, in all honesty, we're not going to see the benefit out of them.
Great points, Rob. Unless, Marish, you want to come back in on that, but I do feel that there is a definite theme running through this in terms of the role of patient registries, but then how does that marry with a more population-based approaches? And Marish, you've touched on something that you'd like to see coming through, but I guess a question that I would probably share with Rob in terms of pulling that data that is collected in other sectors to be able to answer those questions that have been valued by the public. It's those kind of unknown unknowns, those questions that you're looking to answer. How ready is our system right now for that kind of pulling together? And what maybe role would legislation provide in terms of using data for those kind of secondary purposes? Where do you see that going, Marish?
I think we're very poorly equipped at the moment, Derek, to kind of draw the inferences across different specialties. I think we're flying quite blind in that respect. I support what Rob has said, and like the challenges, the management of data is a core skill now across a load of sectors, and health has a huge challenge to secure its fair share of those skill sets. And I think it's really important that countries organize those skills and in sort of the most effective ways. On the issue of the top down and the bottom up, I suppose it's one of the lessons, like basically we didn't succeed in securing the kind of national level allocation of investment that would have been needed, say, to kit out IHRs through the acute level, the community level, the GPs. Now we were kind of had a sense of phasing out and sort of building up the capability technically across all services. But the Irish health and social care system is so complex. The legacies of voluntary, public, private are enormously complex. Even the public system, as I described, is totally disconnected from itself in terms of social care, community care, respite care. So that's why I was saying that the health services need to assign responsibilities for population health. And that's how you get the teams, because people have to work together, because they share a responsibility for the health outcomes of a known population. And on the kind of citizen driven and what citizen enabled to be the driver, as Evelyn Moreau has said in the Q&A, that's where my thinking is going now, just on the basis of the instinct people have. And I think people haven't the patience for the kind of slow pace that Ireland has displayed over recent years. And I take responsibility for that. It hasn't worked going top down, trying to get everything kitted out and then get all the data sharing agreements, crisscrossing cross voluntary, private, public. It's not going to work that way. So that's where I'm thinking the state reaching out much more directly to citizens with a legal basis, and committing to ensuring that citizens have a core minimum data set. And as I say, we could start slow, and you can get into the fancy stuff of people's sort of personal wishes for their own end of life care, or these kind of advanced care notices are really, so there's really nice stuff that a health system can do. We talk about prevention and supporting well-being as well as intervening with illness. I mean, people having access to their own information can support those kind of approaches. So that's where my mind is going, a kind of establish a right in law for citizens to have their information, and establish a responsibility in law for anyone that provides a health and social care service to any citizen in Ireland to support their maintenance of accurate information.
Thanks, Marish. Loretto, you have your hand up. Do you want to come in on that question?
Yeah, thanks, Derek. And I do think we are in a bit of a hurry here, and particularly I look at some of our younger, but also just our general population. They have applications on their phone now. None of them are regulated. They want to manage their own health information. So you talk to any advanced practitioner now who's managing, say, cardiology, diabetes, huge percentage of patients are coming in with an application on their phone that they've downloaded to help them manage their own health information. Like I said, unregulated, there's a huge, citizens want to be able to manage their own information. They want to be able to track their blood sugars, they want to be able to track their HbA1c, they want to be able to track their own health. So we need to get on top of this, because what's going to happen now is we're going to go from, we have challenges in information, but we now really are going to go from to having information everywhere. We have vendors coming into the market, ad lib, and data is being stored in their clouds. Some of it's coming into a process, some of it's not. None of it's connected. The IHI isn't seeded into most of those applications or systems or solutions. So I think there are core, and again, it comes back to those fundamentals, defining out those and putting infrastructure, legislation, whatever is required in place, and simplifying. But again, that top-down approach, I think we've figured that doesn't work. And in terms of the complexity piece, like Google have just dropped they had a huge health project running, and they've just, I think about 2 weeks ago, left it behind because it was too complex. They figured out that health is really complex for what they were trying to do. But if we don't get a handle on this and look at things like citizen health portals, Amazon and others have got major projects. They'll be sitting on an application on your phone, and they'll have all your health information, not us, not the government, and not the citizen. And there are challenges coming that we need to kind of, I think, wake up to pretty quickly.
Thanks, Loretto. Great points. Sarah, you have your hand up. Do you want to come in?
Yeah, thanks. And yeah, I just wanted to kind of echo what Loretto was saying regarding the kind of the level of access to personal health information that is shared outside of the healthcare system. Also, I want to recognise Claire Harney's and Pascal Darien's comments about how to ensure that a new system is actually going to be used appropriately, how the practitioners within that system understand the importance and rules around private health, personal, like patient health or personal information. I know that GDPR and FOI policy is usually what's used in reference to this. I think based on like Loretta's comment there as well, we need something that has a much grander scope, that is able to be even be preemptive about future technologies that are coming in. So there is a huge body of work that is needed to be done, and it can't just be a reactionary thing. We need to look forward. You know, I'm in my 30s. I'm in a generation of where digital health is going to be my entire future, and that's the first generation that will have that. So for me as a citizen, I need to understand and need to be reassured that there is going to be a system in place that looks forward to my next, hopefully 50, 60 years.
Thanks, Sarah. Very important message to keep at the center of everything we're doing is that, and in fact, many people on this call will recognize in terms of that next generation, that the first generation to have maybe digital access to either a summary care record or a shared care record and ultimately an electronic health record will be, I think, a key driver of the change that's necessary and the
Have we lost Derek there, folks?
I think so.
He was just midstream.
Yeah, I think he's gone. Someone starts singing Let It Go.
You have a look at some of the other Q&A and bring us through some of the other queries?
Yeah, I think we should. There's a lot of good questions in there that I think still need some answers. Take a look.
Sharon, there's an interesting one there from Maria Ryan about the Northern Irish analogy with GPs being employees of the health service more directly in the north and probably having set populations of patients. I do think that's a stronger approach for like Sláinte Care insofar as it commits to a national health service, as I understand it does. I think that is the ideal model where GPs are employees. In Ireland, we have the peculiar situation where their money still comes from the taxpayer by and large, but we don't have a sort of a clean cut, a public universal system as I think is policy to have. I don't think it's a showstopper, and I think it's part of the reason that I've been talking and I'm hearing it from others about a more citizen-driven approach is probably the most effective way for Ireland to work in the complex sort of system that we've inherited. And then implementation of Sláinte Care is absolutely vital, I think, to develop supportive structures that build on that information.
Thanks, Maurice. I'm back in, so please accept my apologies for the connection in my own house. But what it's also done is that it's meant that I don't have access to the Q&A anymore. So in terms of maybe for the last 10 or 15 minutes today, it would be that I think in terms of a common theme that's coming through here is the need for a collective approach here, and that I think the department's intentions are I think as a first step, it would be great to get an idea, at least as Loretta said, a roadmap of what the department's intentions are in this space. And I think it's clear that we need a combination of approaches in terms of legislative, regulatory, and citizen-based approaches. But and I think it's perfectly fine to be moving along in a stepwise approach rather than trying to deal with this all in one fell swoop. But Maurice, is that something that would probably be the plans over the next period? I mean, you've said that the National Statistics Board is looking to see the system strategy by mid-22. I mean, is there anything you can tell us about maybe what your intentions are?
I'm afraid, like I say, and I keep saying, dust hasn't settled. I can't determine fully the tasks I'll be assigned, but like I say, I think there's a growing appreciation of how vital some of the fundamental issues are. The health system will get dragged towards the urgent, where the fires are. But I do hope, and I mean, when you look at sort of the big developments, the transformative developments that happened in other jurisdictions, like it was from the ashes of World War II that other countries implemented sláinte care, basically. Ireland has never made the effort to do that, until sláinte care. I think there has been anxiety about the pace and the kind of momentum behind sláinte care, but I do hope that the pandemic and the crisis that it is give us that kind of scale of ambition, because I do think it does show the vital importance of information in a health service, the vital importance of coherent national approaches, and how I think health is a communal thing in many ways, much more than we realized. And I think some of the kind of age-old difficulties in Irish health service, and some of them coming through the Q&A, the very peculiar mix of public and private, just is more unacceptable, I think, than it was even before the pandemic. So I'm very sorry. I'm not sort of dodging the question, but we just haven't. The department is going to be restructured, just to get face into the core issues. The Robert Watt is very adamant that a small number of core priorities are pursued. It's very hard in health to do that, but that's the intention, and it's in that context that I'll be championing the health information. I don't want it to take as long as it took before. We were kind of meandering through all the complexity before. I think that's an important stage. But I'm minded now, if we get the green light, I would be looking to do heads of a bill at the same time as doing a data strategy, because we've enough strategies. Thanks.
Thanks, Maurice, and thanks for your candor as well on that particular question. I don't think you're avoiding questions here. It's very much the perspective here is that IPPOSI can play a role, I think, in terms of channeling both patient and public perspectives, but there does need to be a number of engagements before any heads of bill needs to be put together. And I'm thinking particularly for the research community, in terms of the way that research gets viewed through a certain prism and through a certain lens at the policy level. Certainly it's encouraging to see that both research and innovation, in terms of what you've presented, Maurice, is very much to the forefront of your thinking. And I think it would be really important to devise specific engagements for the consequences or the implications for research of any changes that certainly for primary legislation would be coming down the tracks. So I might point to maybe Rob at this point in terms of, so there's still the kind of common questions coming in around the registries discussion, and it's very much, there's a couple of elements there. There's the ability of registries and the data within them to support research and innovation. But as you say, that the real need to have a coherent approach to supporting them and having a sustainable approach to that. It seems to be really the key kind of common theme that's running through a lot of the questions. Is above on what you've already presented about the need for, I think, greater highlighting of research. Are there other initiatives? I know that the Ferris and certainly Simon Harris and Jim Breslin are trying to push a public engagement process around, well, what are the questions the public want answered from a research perspective? Is there any other initiatives that maybe you're aware of that we can be harnessing in this regard?
To be frank, there's nothing that I'm aware of at the minute as you pose the question that I can kind of see coming down the line. I think a lot of systems are trying to connect in the background. So, for example, I know that our clinical trials and our cancer trials infrastructure connecting in with things like the registry is a very important kind of aspect. I do worry, though, that ultimately we have to have the right mindset before we go into these things as well. And we focused quite a lot of our discussions here on some of the technical aspects, some of the individual elements, the enablers, and so on. And I'm minded again of one of the points that Murray makes. We have an awful lot of reports in this country around health. We have an awful lot of reports around scandals that took place in our health system. A lot of that stuff is sitting on shelves, including my own, back in my own office, gathering dust. I think there's an urgency now around action. I think there is a need to incentivize what it is that we need, and each of us find a way to link in around that. So registries are an important enabler around understanding of certain individual diseases. But I don't think we can wait, to get all of these kind of working. And sometimes we have to kind of kick off. We have to make sure that there's appropriate governance and that people can trust what is going on in these places. But we have to start moving forward. We have been waiting a long time for some of these things to kind of come together. And indeed, Derek, I know you probably decades now at this stage, because we've been at the same meetings where we've been hearing the discussions. I remember some of the great stuff that Richard Corbridge was promising back in his time, in his tenure, and indeed other people that are both in the group here and wider attendees. So I think there really is an urgency now, and if there's one element there, I think that urgency that came, back to our topic, came from COVID, has to be brought in, and we have to all find ways to get in behind that to be able to deliver the improvements, because things are moving on. I'm getting older. My risk of getting lots of other diseases, etc., is growing in the background. So from a selfish personal perspective, if we don't get that right, I may not have the health outcome that I might otherwise be able to enjoy if I was in another jurisdiction, etc. So I think we're talking about individual elements, but actually we all need to recognize the urgency around that bigger picture, that there are things that we can do now, today, around health, that there's investment that we need to put in. There's a skill set, there's a deficit in training. Again, I know from the registry perspective, that there are challenges in getting enough skilled people, and that's just in one registry. There are challenges in getting enough skilled people. I think the department is seeing that as well, of actually where posts are created, it's now a difficulty to get enough people in. So I think we need to look at our system, see what it is, and get going. And we need some measure of KPIs. Like, one of my readings from the Sláinte Care is that, again, there was a great plan there, but time is moving on, and we're not looking at it and saying, hang on, we said we would be at a certain place at this stage, but actually we're not. Okay, we need to shore that up. What's going wrong there? So I think we can do an awful lot of talking around these topics, but actually we need to get in and get into the battle and start kind of moving forward. Registries are one small element of that, but the wider problem is actually recognizing that we need to get going and we need to move on, we need to learn, and we need to be accountable to ourselves as to whether progress is happening, and accept that with any complex system, yes, there will be mistakes, but if we have the right governance in place, if we have the right people overseeing some of these things, we can make sure that some of these things don't happen that we might be afraid of. And you know, the cyber attack was a very good example. Lots of people had flagged that up front, that this was a major challenge for our system. And unfortunately, investment wasn't put in, and people now are very afraid of some of the implications of health data as a result of the fact that I still get dozens of calls a day on my personal private mobile number that is only accessible through a HSE system, because I was in as both as a patient and so if we don't get those things right, and if we don't move with urgency, I think we really don't do ourselves a service. And me selfishly and my family might lose out on some of the benefits that they might otherwise see.
Thanks, Rob. Both Murish and Loreto have their hands raised, so I'll go maybe Murish first and then Loreto.
No, thanks, Derek. I just wanted, I'm glad you asked about research, and I just wanted to convey that while I haven't mentioned research, my whole motivation for sort of getting the health data strategy, getting the health information moving correctly on a clear legal basis, is to support research and to support the DAZZLE model developed by HRB in consultation with others over recent years. When I read the IPPOSI citizen jury, what I read in it was a further very strong endorsement of that DAZZLE model. And sorry if I'm speaking gobbledygook, the DAZZLE model is about addressing the flow of health information in the delivery of service, and then using the information generated in the delivery of service in de-identifying it, and then having population-based sort of databases that correspond precisely to known populations in Ireland. So actually, this mission and vision for a research-infused health service would be hugely developed by that. So it's the same exercise, it's the same project for us inside the Department of Health, the resolution of health data policy and the promotion of research. And in ways, it kills me how inefficient the current service is, whereby you have an awful lot of sort of attempt to capture information, to define populations, to sample within that. All this energy that goes into that is quite unnecessary if you had the system organized properly. And I think, and this is where the population-based approaches come in, I think health doesn't benefit sufficiently, doesn't pull in the information that's generated in other quarters, like the central statistics, all that, and health doesn't contribute enough back into that national statistical infrastructure. So I think that there are ways where basically the whole Irish population could become the subject of research on the efficacy of different approaches. And I think that's the goal we're going for. And just because I haven't said research, it's not a next phase. It is almost resolved in the same legislation and in the same strategy and approach as we're discussing here today. Thanks.
Thanks, Murish. Loreto, do you want to come in there and add something?
Yeah, no, sure, Murish, thanks, sorry, Murish, Derek, apologies. No, I think we now need to stand up and we need to be really, really honest about where we are. We need to actually be really honest about what's crippling us, because, and I don't use that word crippling lightly. We are crippling ourselves in the country. And I think we have such an opportunity to get things right for all of us. And this isn't just for the Department of Health or the HSE or various groups. It is for all of us. And we really have to call out where we are. Like where do we want to get to, and what are the gaps? And like I said, we need to just call out what's crippling us, the process, that the people, and be really honest about all that. And again, use that collective intelligence. We have got really good people in our system. We've set ourselves up like the clinical care programs and other infrastructure that we can really use well towards this agenda, except we're not connected enough. We're not using our collective intelligence. And we do have gaps in terms of capabilities, certainly in the whole analytics and reporting and statistics and etc. But I think now we really need to start calling out those and just move forward. Thanks, Derek.
Thanks, Loreto. Just for information purposes as well, and I'm conscious that Murish has to get to another meeting after 12, but so this is the first in a series of digital discussions. As Rob has said very clearly, we don't want to be just having discussions. We want actual impact, and we want to see outcomes of these. And this series of discussions by IPPOSI is designed to complement the citizen jury, but also to help move the needle forward on what's needed in Ireland. So for the questions that were coming in around maybe greater detail on those person-centered or bottom-up approaches, I certainly think that the next two topics that we've come to choose in IPPOSI, the next digital discussion will be around the European Commission's plans for a European health data space. And there are certainly elements in that it's very clear what the intention of the European Commission is, to encourage member states to develop their own regulatory and policy initiatives around health information, to share and to use that to further the health outcomes of that country. And certainly the work of those iCitizen and there's a number of very citizen-based approaches being supported by the European Commission. So please watch out for that next digital discussion from IPPOSI. We'll then be following that up with a dedicated one on citizen-based approaches. So again, really kind of focusing on that bottom-up approach and how we can go about doing that in Ireland. And that's all coming within the next month or two. So I think any questions that maybe didn't get answered today will hopefully get greater fleshing out in those discussions. So I'm glad to see that we've chosen topics that are of relevant to the audience today. So I actually think that what Loreto has said in terms of that common call is actually a good way of summing up our discussions today. I'd just like to re-emphasize the fact that we do have really, really good people working in the system, and some of them are on the call today. And I hope that we've managed to address at least some of the questions that have come through. There will be a report that will follow from this event, and it will dovetail with the reports coming from the other events. And I certainly look forward to seeing more, certainly of our citizen jury representatives. And thank you indeed to Sarah for joining us today. Thank you to Murish, to Rob, to Loreto, and to everybody for joining us. It's been, again, a really insightful and really useful discussion. The question is, what's the impact and what's the outcome? So we look forward to working with everybody towards those particular outcomes. So without further ado, and without any further technical difficulties on my part, I want to thank everybody again. Wish you all a good, safe and happy Monday. So thank you again.